Good morning, ladies and gentlemen. For today's CPC, we have a very interesting case of 36 years old male who is a diagnosed case of cryptococcal meningitis, but I'm sure there is something more than just the cryptococcal meningitis. So we have with us Dr. Kartik, Assistant Professor in Department of Neurology, and he shall be discussing the clinical protocol.
Thank you, sir. Good morning, all. Today I'll be presenting the clinical protocol of the staff CPC. We have a 36-year-old male who's a leather shoe factory worker from Agra. He was admitted with us from 11th of January and died on 22nd of January. He presented with the chief complaints of headaches and seizures for the last 1 month and gait disturbance and vision disturbance for the last 1 week. He had a history of headaches from 9th of December, which were holocranial, associated photo and phonophobia radiating to the neck. It was a maximum VAS score of 7 to 8, which gradually progressed to 10 out of 10, followed by history of loss of consciousness. He had his history of, he developed seizures, which were initially left focal with secondary generalization, multiple episodes on 2 to 3 per day. It was associated with hallucinations and started on oxcarbazepine 600 milligrams per day. Based on an MRI, he was given IV methylprednisolone pulse for 4 days on 24th of December, following which his seizures completely abated. A week after the injections, the seizures came back with a vengeance, followed by disturbance in gait in the form of swaying while walking and slurring of speech, and visual symptoms in the form of horizontal gaze diplopia and diminution of vision in the right eye, with some color desaturation. He denied any history of fever or loss of weight or constitutional symptoms in the past. There was a significant past history of jaundice with history of complementary alternate medication intake, history of tobacco chewing, significant tobacco chewing, occasional alcohol consumer, and history of promiscuous sexual behavior that was given by his brother. On examination, his general physical only revealed a pan-digital clubbing, otherwise his respiratory, cardiovascular, and per-abdominal examination were completely normal. His neurological examination revealed that he was not oriented to time and person. He had some mild frontal impairment, neck rigidity was present. He had bilateral visual impairment, a pale optic disc, bilateral 6th nerve, right 12th nerve. And his motor and sensory examination, though normal, he had absent knee and ankle reflexes with extensor plantars. He had a pancerebellar involvement. And in his investigations, he had a neutrophilic leukocytosis with some microcytosis. In his left ENRFT, he had a terminal, he had a hypokalemia with terminal AKI, and terminal, he also had mild transaminitis. He had also had a hypertriglyceridemia of 536. His blood glucose analysis towards the end showed evidence of metabolic acidosis with hypoxia. I'll request Dr. Vikas to present the radiology.
Very good morning, all. So, in this patient, we have a set of MRI which was done on 13 January and with few repeat sequences which were done on 14 January. So, we'll first see the axon and flare cuts as from cranial to caudal. And here we can see there are multiple hyperintense foci which are predominantly involving the subcortical white matter region with prominence of VR spaces. We can again see that the distribution is predominantly along the arcuate fibers and subcortical in location, again the frontal and parietal lobes. Here again we can see these lesions. Also we can see there is mild periventricular hyperintensity with slight rounding of the ventricles. Here again we can see there are involvement of these hyperintense lesions involving the bilateral basal ganglia, more so toward the left side. Involvement of the occipital lobes, again subcortical distribution can be seen here. We can see similar lesion in the temporal lobes as well as the few foci in the right cerebellum here. Again, these coronal T2 sequences, we can see that these prominent VR spaces here, and also this rounding of these ventricles and periventricular hyperintensities. There is also mild brain atrophy. On T1 weighted images, we can see all these lesions are hypointense with more hypointense foci in the left basal ganglia region. On diffusion, this lesion in the left basal ganglia shows intense restriction. Again, few diffusion foci of different age, slightly older, were seen in the bilateral frontal lobes and one lesion in the subcortical occipital lobes. So we have these diffusion restricting foci of different ages. On SWI images, there was no evidence of any microhemorrhage. However, there was evidence of some venous congestion here. These are the post-contrast images, and we can see these, a few of these diffusion restricting foci. They shows nodular type of enhancement. Also, we can see there is a diffuse pachymeningeal enhancement, and involvement of the ependymal enhancement is also appreciated here. And we can also see some evidence of basal meningeal enhancement. On MR angiography, there is evidence of these mild attenuation of the cortical branches of the bilateral posterior cerebral artery as well as the middle cerebral arteries. Mild attenuation was noted. These are spine sequences, and we can see there is thickening and clumping of the cauda equina nerve roots. Which shows post-contrast enhancement, we can appreciate here. Also, there was enhancement of the left erector spinae muscle, the paraspinous muscle was showing enhancement. And the body, the transverse process and the spinous process of the L2 and L3 vertebra also showed enhancement. So there was evidence of this osteomyelitis of these areas with paraspinous soft tissue. So to summarize the radiological findings, there are multiple T2 and FLAIR subcortical hyperintensities, prominent VR spaces, mild periventricular hyperintensity with pachymeningeal, leptomeningeal and ependymal enhancement, small ischemic lesions, few parenchymal enhancing lesions, mild attenuation of cortical branches, enhancement of the posterior elements of L2, L3 and thickening enhancement of cauda equina. So based on these findings, the possibility of infective etiology is more likely. It can be cryptococcal infection, but based on these findings, the co-infection with the neurobrucellosis, TB and fungal should also be kept in these cases. Thank you.
This patient, thank you, Dr. Vikas. This patient later underwent a CSF. He came to the emergency bus on 8th of January, but he was sent Lama from that day. At that time, he had a CSF showed 1900 cells, predominantly mononuclear with traumatic TAP. Protein was 63 and sugars of 10. The culture at that time also grew Cryptococcus neoformis. And repeat CSF done on 15th also showed, had showed 8 lymphocytes only, 50 with a protein of 53 and sugar 2. And the culture also grew Cryptococcus neoformis, and gene expert and AFB were also negative. And I'd like Dr. Sangamitra to present the cytology that was done in this patient.
So this is a low-power view of the cytospin smears of the CSF that we received, and here we can see that it was very much cellular. On the higher power, we could appreciate these variably sized spherical to oval-shaped E's forms, and here we can see that these E's are surrounded by a translucent capsule as well. The yeast per se has taken up the Jamesa stain, and apart from this, we can also appreciate the replicating forms of these yeast in the form of narrow-based budding, which is also well appreciated in the PAP stain. This is a narrow-based budding, so this morphology conforms to that of Cryptococcus.
Thank you, Dr. Sangamitra. So the rest of the investigations, including HIV, viral markers, hepatitis B and C were negative. VDRL was negative. His 2D echo revealed a mild concentric borderline LVH. Coagulograph was normal. His blood culture grew positive for Cryptococcus and later Staph hominis also. The procal in the terminal stages was increased. In the hospital here, random blood sugar varied between 200 to 450. He was on steroids, around 25 milligrams of dexamethasone per day. And we also had gotten an immunological workup. His absolute lymphocyte count was 1500. His CD4 count was on the lower side, 400 cells. But it an increased CD8 cells. The immunoglobulin profile, IgA, IgM levels were normal, but his IgG levels were in the lower borderline. So in this 36-year-old male who had presented with history of headaches, seizures, ataxia, and visual symptoms, clinical possibility of a meningoencephalitis with vasculitis versus a malignant lymphoma was considered. However, the CSF workup was suggestive of Cryptococcus, so we started on amphotericin and fluconazole, along with the anti-seizure drugs of levetiracetam and oxcarbazepine. After 3 days of starting antifungals, he developed an episode of generalized non-nuclear seizures, followed by a cardiac arrest. He was revived with CPR. However, post-CPR, his GCS deteriorated. He had a GCS of E1, M1, VT with fixed and dilated pupils. Post-CPR, he continued to have hypotension and hypoxia and started on inotropic support and ventilation. In view of increasing ventilatory and inotropic support and fever, he was started on meropenem and vancomycin. A trial of dexamethasone was also added, considering the possibility of aniris. On the terminal day, he developed intermittent episodes of refractory ventricular tachycardia. He was started on amiodarone infusion, but he had suffered cardiac arrest and he could not be revived. He was declared at 7:45 a.m. on 22nd of January. So the unit's final diagnosis was cryptococcal meningitis, post-CPR status, aspiration pneumonia, and refractory septic shock. So what we have in the database is a 36-year-old male who worked in a shoe factory, significant history of tobacco, promiscuous sexual behavior, past history of jaundice, and history of complementary medicine intake. Clinical examination has revealed meningoencephalitis, arachnoiditis, optic neuropathy, multiple craniopathies, clubbing, and an MRI which suggests of meningoencephalitis, choroicular clumping, some osteomyelitis, blood and CS of growing cryptococcus in an HIV negative individual. So I'll be discussing this case under three headings: what was the basic disease, the predisposing condition, and the terminal events. Let's first address the elephant in the room. The patient definitely had a disseminated cryptococcal infection, disseminated being defined as a cryptococcemia or positive culture from two different sites. We know the brain was involved. He had definite leptomeningitis, encephalitis, vasculopathy, and arachnoiditis. I know the lungs are involved because the entry port of the cryptococcus is through the lungs, and the chest X-ray mentioned some lung opacities, and terminally also had ERDS. But I'm not sure about the other systems. There could be some multifactorial involvement also. He might have some transaminitis, AKI, cardiac, but these can be contributed by his basic other illnesses also. So how common is cryptococcal meningitis and vasculopathy or infarcts? The incidence varies between 4 to 18% in HIV-negative individuals. Multiple infarcts, as we have seen in this case, are much more common than single infarcts. The infarcts are predominantly seen in the basal, around the lenticulostriate branches, where the capillaries penetrate, particularly when you have cryptococcus surrounding the Burke-Robin spaces. Mechanisms that have been postulated are strangulation of the vessels by the exudates at the skull base, vasculitis, or secondary vasospasm, or thrombotic occlusion. Arachnoiditis is something very rare that we see in cryptococcal meningitis. We don't see it rarely because we don't suspect it. Usually these patients present with UMN symptoms. Fortunately, we could see that patient had some absent reflexes, so we looked at the spine, we got arachnoiditis. And the presence of arachnoiditis suggests there could be associated leptomeningitis due to an immune dysregulation rather than extensive disease. So, could it be tuberculosis? Yes, definitely. The clinical picture that you have meningoencephalitis, craniopathies, hydrocephalus, infarcts, osteomyelitis, distal clubbing, this all could be seen in tubercular meningitis as well. However, the odd points are that he didn't have any constitutional symptoms, no exudates, no tuberculomas, and even the CSF workup was not suggestive of tuberculosis. But that doesn't exclude this patient from having tuberculosis. We have a lot of case series of tubercular and cryptococcal meningitis occurring together. A large body of data available from HIV positive individuals. The incidence of co-infection varies between 0.8 to 8% in the large series. And 21% of all individuals on cryptococcal meningitis in HIV have received ATT, some form of ATT or the other in the past. And the prevalence of HIV negative individuals with co-infections is only limited to case series. But when you see the pattern of involvement of meningitis in in HIV negative individuals between cryptococcal and tubercular meningitis, our patient ticks all the boxes. He had a higher median age of onset as compared to the tubercular patients. They usually present with headaches and vision loss, which was there in this patient. Tuberculosis usually presents with headaches and systemic symptoms. The mean delay in diagnosis is much higher for cryptococcal meningitis than for tubercular meningitis in an HIV negative individual, because we usually don't suspect cryptococcus in a non-HIV individual. The CD4 to CD8 ratio are much lower when you in a cryptococcal meningitis in HIV negative as compared to tubercular meningitis. And the lacunar infarcts are much more common than in tubercular meningitis. We have mentioned that he was a leather handler. We don't know whether he was working with processed leather or unprocessed leather. We still consider whether he could have exposure to brucellosis. Brucellosis mimics tuberculosis in many ways, predominantly the osteomyelitis, the arachnoiditis, and meningoencephalitis. We suspect a lot, but we hardly get any time positive. Again, the odd points in this are that he doesn't have any constitutional symptoms, no fever, no arthralgias, no cytopenias. They usually have associated transaminases. But still, this can be a less likely possibility. So when we see these patients of disseminated cryptococcus in an HIV-negative individual, we have to look for the risk factors. If you look at the risk factors for cryptococcal meningitis in HIV-negative individuals, he's not an organ transplant individual. He's not suffering many autoimmune disorders as far as we can see on the history. He did have history of some liver involvement in the past for which he took CAM, but the synthetic functions of the liver appear normal. The albumin and the coagulum appears normal. And he didn't have any other decompensation of liver in the histinocytis till now. So it's very less likely. And we cannot rule out whether he had a primary malignancy lurking around which predisposed him to a disseminated infection or some underlying adult onset primary immunodeficiency disorder other than HIV. But we do know in the presence of a low CD4 and CD8 ratio and borderline IgG levels. But we do know in the this patient did have history of complementary alternate medication intake for all these years. He had a history of jaundice. He took some local medicines which resolved spontaneously, and he was given steroids outside, based on just an MRI report that was reported as demyelination. So yes, he could have been taking steroids for a very long time. We don't know. And you see, malignancy is something that can predispose to a disseminated cryptococcus in this patient. The secondary meningeal enhancement can be seen in malignant secondary meningeal involvement of a systemic malignancy. Systemic malignancy can itself be an immunosuppressed stage, can lead on to disseminated cryptococcus. And yes, these patients do have some response with steroids that was seen in this index patient. However, infarcts are very atypical in malignancy unless and until you have an angioinvasive, like an angiocentric lymphoma. And so CSF cytology didn't have any malignant or atypical. But we don't know. I don't have any evidence of a systemic CT chest and abdomen being done, so I cannot completely rule it out. So whether this patient had other primary immunodeficiency disorder, the genetic forms of diseases which cause disseminated cryptococcus are a dime a dozen. So I'll not be talking about all these. I might look at some of the common ones. CVID is considered when you have low IgG, low CD4 to CD8 ratio. They can have associated autoimmune hepatitis, but it's not likely that this patient would have had. He didn't have any history of recurrent infections in the past, nor his children, nor any relatives. MSMD, yes, it could be a possibility. These patients you have come with disseminated mycobacterial and cryptococcal infections also, and they have a disseminated disease. We didn't came up for this disease. Some in the hospital, the diagnosis of isolated CD4 lymphocytopenia was considered. However, CD4 cells were 400. You need a count of less than 300 or less than 20% of total lymphocyte, which is not matching. Even though 30% of these individuals have a history of high successful behavior in the past, you're not ruling out an associated viral infection in this. So did he in hospital suffer a paradoxical immune response? We had mentioned that he had iris. Irisis actually happens when you have immune reconstitution once you start ART or you reduce the immunosuppression in organ transplant. This is predominantly T-cell mediated damage. But also nowadays a new form of terminology is coming up, that is post-infective inflammatory response syndrome. This happens in relatively immunocompetent individuals when you start an antifungal and there is leak of cryptococcal antigens that can cause an ineffective, excessive triggered immune response. That's an excessive macrophage response in these patients. And yes, there is possible role of steroids in this subset. So I'd like to see the terminal events in this patient. I think this patient had a disseminated cryptococcal infection. He was started on antifungals. Possibly that antifungals had released some antigen release with significant inflammation. The patient had cerebral edema and seizures. He had an aspiration pneumonia and cerebral herniation. He had a cardiorespiratory arrest because of cerebral herniation. He had a for which he underwent a CPR. Meanwhile, the ARDS from aspiration pneumonia and sepsis took over. There was myocardial involvement, dyselectrolytemia. He had a refractory septic and cardiogenic shock, followed by he suffered irrefractable cardiac arrest. So my final diagnosis will be disseminated cryptococcus, yes, involvement of CNS in the form of meningoencephalitis, leptomeningitis, arachnoiditis, possibly inflammatory response syndrome. He would have had a cerebral edema or a bleed, which led to a cerebral herniation. I do expect some dissemination of cryptococcus in lung, cardiac, and renal involvement. Possible hepatic, he would have had some evidence of previous hepatitis also. I still have to rule out whether he had a co-infection with tuberculosis or not, or brucellosis. But it's very difficult to whether we can see any evidence of immune deficiency disorder or depletion of white pulp in the spleen, something like that. He had an aspiration pneumonia with sepsis and septic shock. Of course, in hospital, he had glucocorticoid-induced hyperglycemia and hypertriglyceridemia. Thank you.
Thank you, Kartik. Now you can come and join me here. I will request all the residents to please occupy the seats. There are plenty of vacant seats. Please come forward and occupy them and sit properly. So Dr. Kartik has put up a co-infection with TB in this patient of cryptococcal meningitis. Suppose this person's MRI is given to you. Do you think that this is very much compatible without any basal exudates? Yes, Dr. Vikas, would you say that without basal exudates, without defined meningeal enhancement, it could be, or it's only because it's being discussed in CPC, that's why you're considering TB? Please.
Sir, there was evidence of basal meningeal enhancement as well as the ependymal enhancement, and also there is arachnitis and involvement of the L2, L3 posterior processes also, which is slightly rare to be involved in cryptococcal. It has been reported, but it more suggests towards some granulomatous etiology such as tuberculosis. It has to be kept in a differential.
Yes, the treating unit would like to add something. The person was admitted under neurology. Yes, ask them. I'm pretty sure about it that you would have looked at MRI and whether TB was considered antemortem or...
Sir, I think the another clue was the MRI of the spine. The way clumping of the nerve roots is occurring. Co-infection or arachnoiditis has to be thought. I mean, because this the clumping of nerve roots would not occur otherwise in a primarily parenchymal lesion. So along with that, definitely arachnoiditis was there. And given the current situation, nobody can rule out cryptococcus. I think the way we have seen the beautiful slide with lots of cryptococci in there. So hence, I think even I would consider both co-infection.
No, I was not considered antemortem.
No, sir, the primary focus was cryptococcus. And as we are just talking about the paradoxical immune response, even that was considered as one of the possibilities causing excessive arachnoiditis. Definitely we are considering it at the given moment, because now we are retrospectively looking into each and every detail.
Yes, Dr. Inder.
So there are two things which have not been explained. One is pan-digital clubbing. So why was this patient having pan-digital clubbing? So if we assume that he had some immunodeficiency disorder, given that he has an IgG which is at the lower limit of normal, although the guidelines suggest a cutoff of 5 grams per deciliter, this patient had about 6, which could also be explained by steroids if he had received previously. Just mere demonstration of IgG, even if it is low, it can still be CVID. Probably this patient needed further workup because they would have normal T cells. It's only that you have to demonstrate the dysfunction of T cells, and perhaps that could be one predisposing condition for this patient to have. Whether arachnoiditis could also have been there can be explained by cryptococcus. If we are to assume that arachnoiditis was because of TB, it should have shown at least in the CSF, because it means that the TB is there and causing an inflammatory reaction there. Probably a gene expert ultra would have picked up, given the high sensitivity that it has. So I think this patient, if I have to explain everything, I would still consider a primary immunodeficiency disease in this patient. Probably he had some underlying chronic lung disease, which would perhaps explain his pan-digital clubbing.
By chronic lung disease, we are suspecting...
You can keep on writing all the questions, because I'm sure that many of these questions we have to answer.
Sometimes bronchiectasis can go on for a long duration of time. Patients would have recurrent infections, and we are not sure. They may not be forthcoming with the history. They would only tell you what they are experiencing now. So perhaps...
All right, now we have Ritu followed by Modi, and at least I can see, everybody is looking from his angle, Suddenly when the immune deficiency comes up, there are about 10 hands from immunology unit, from chest, somebody has come up, now 4 neurologists, so please. Yes.
So there's always a confusion between tubercular meningitis and cryptococcal meningitis. However, there were some atypical points in this patient, that the patient did not have any loss of appetite, loss of weight, did not have any fever. And despite having vascular infarcts, the exudates were not that prominent, as Sanjay Jain sir was also saying. However, TB was considered in this patient ante-mortem and very strongly considered, sir. But ATT was not started because ultragene expert was done and it was negative. And the CSF was full of cryptococcus. And the culture was also done and the drug sensitivity was positive.
Everything is there, in front of you. It's how you interpret. Yes, Dr. Modi. It's very easy for me to sit here and make comments, smart comments, but when you treat a person, you have to treat like an individual. So I always say that you have to see the whole patient rather than looking at one component, and you can keep on discussing that component. Yes, Dr. Modi.
Sir, because
First,
it is
tell me,
CPC,
frankly, would you consider TBM or not?
the answer is a big 100% yes. If given a choice, if cryptococcuses was not there, I would have treated with ATT only. The answer is very simple. Posterior element osteomyelitis. The differential diagnosis is nothing. Number 1, number 2, and number 3 is tuberculosis. It may be there because we are dealing with CPC, so we discuss everything which is rare. But in life, had there been no cryptococcosis documented, the case is clear-cut case of tuberculous meningitis with arachnoiditis, with osteomyelitis, with complications. No differential diagnosis. So we always teach, we always discuss, cryptococcosis is a close mimicker. It has to be ruled out. And I think there is ample literature to say that. And on top of it, we are treating one patient of dual infection right now in the ward. He has osteomyelitis, but he has cryptococcosis, which is positive. He has gene expert ultra, which is positive. So dual infection was very rightly, thoughtfully kept. And but if you ask me, would you consider tuberculosis? The answer is a big yes to this one.
All right. Okay. Now we have 6 hands to yes. You can start. So let us talk of the things which we can document. Otherwise we can always keep on discussing whether it is there or not there, because at this moment I doubt very much that you can show any immune deficiencies, because then I would, we have to restrict. Yes, please.
So we have a disseminated cryptococcus here, and we cannot disregard the fact that the CD4 count is just 400. So whenever disseminated cryptococcosis is there, as immunology, we will consider a combined immunodeficiency where there is T cell dysfunction. And we have had patients with MSMD, Mendelian susceptibility to mycobacterial diseases, where they can have a disseminated cryptococcus infection. Unless we do a molecular analysis, we can't be sure. We can just put in here it's a combined immunodeficiency or an MSMD. But for the final answer, we need a molecular workup.
Yes, now we have. Yes, please. I could see one hand from a resident from the back. Somebody wanted to say something. No.
Adding on to the CVID part, now this patient is an adult who has had 2 distinct episodes of jaundice. So that with mildly elevated transaminases, and the patient took some complementary medicines, and the bilirubin seems to be normal now. So there's a chance that this patient might have an underlying autoimmune hepatitis, which would have responded to CAMs that are laced with steroids. That, in addition to a borderline CD4, a borderline IgG, kind of again adds to the possibility of CVID here.
Yes. Any other comment if you want to add other than being theoretical? Any other possibilities before I hand it over to Kartik to make comments? Yes. Well, we can discuss it later because the time is short. Yes, Kartik.
Yes, as we have considered the possibility of CVID, definitely we have seen the CVID can be associated with chronic lung infections, can have bronchiectasis, can explain the distal clubbing. That is one of the primary differentials that we consider. But the number of and yes, cryptococcosis has been documented in patients of CVID. The second point is whether the patient is autoimmune hepatitis or not. The patient had the history of CAM intake and his recurrent episodes of jaundice. We can expect in CVID patients, you get focal nodular hyperplasia, can have intermittent obstructive jaundice, can have intermittent hepatitis also. Another question was whether tuberculosis. Yes, the tuberculosis is a very close differential of cryptococcal meningitis and brucella. And we should also remember, this is not an HIV positive patient. He's a relatively immunocompetent patient, as we have seen in the last student clinical meet also. In HIV negative individuals, the pattern of meningeal enhancement of the pattern of radiology can be a little bit different than what we see in classical HIV positive patients. Thank you.
Yes, now it's my pleasure to invite Professor S.K. Gupta. You like to add something? No, I just want to thank you also because he came in the last minute. I requested him at least so that some participation is there, because these are the people who deal all the complications of all these chronic meningitis patients.
So the patient didn't come to us because he didn't have any surgical problem. But I agree with what Kartik has presented. Cryptococcal, only odd thing is presence of an osteomyelitis, as Modi said, and arachnoiditis. So that's why I would consider a dual infection. Cryptococcus primarily with secondary tuberculosis. Or other way around.
You know, there are 10 infections which can present like this, I can name. And unless you start looking for it, you won't find.
Brucella does present with the significant history of fever, myalgias, arthralgias, and the investigations you will get to see cytopenias predominantly. Nothing was there in this patient, but yes, the brucellosis and tuberculosis mimic each other, neurobrucellosis and osteobrucellosis. So we cannot, we are not suspected in this patient in antemortem. We have not sent the workup actually. Looking back in this MRI, we can say it could be.
Any other comment for, yes?
Just that we completely ruling out HIV, there was a low CD4 relatively with risky sexual history, and one test we did. Of course, that is negative. But is there still possibility that it could be underlying HIV disorder? Because, you know, the setting is like that. I'm just wondering.
Yes, now I'll invite Kirti. Kirti is smiling. I know. Let us see what she has to show.
Everybody, and thank you, sir. I'm glad it generated a bit of discussion. So I'll start with the autopsy findings. And this was a complete autopsy on this 36-year-old male who had a diagnosis of cryptococcal meningitis. And externally, the prosector noted that he was well built. The serous cavities, all pleural, pericardial, and peritoneal cavities were within normal limits. Accidentally and unfortunately, the prosector had stripped off the meninges during removal of the brain, and the brain was very soft, resulting in quite significant damage to the underlying brain, and the brain got divided in two halves. So the base of the brain and the cranial nerves in the vessels could not be examined. So I'll start with the dura. This is a dura, and seen from the superior aspect, the superior sagittal sinus was cut open and it was within normal limits. No thrombus was identified. The undersurface was also normal. This is the left half of the brain. We see from the left surface, and it was extremely soft. It weighed 1104 grams, and there were parts of cerebral cortex that were kind of separating out from the underlying surrounding parenchyma. No exudates were seen on this surface. And this is the right side, same appearance except for a little bit of softening and breaking down of the cerebral cortex around the central sulcus. So these are the coronal slices of the right half, starting from anterior going posteriorly, and we see that there is extensive softening of the whole of the cortical ribbon, and a portion of this shows softening with irregular gray-white margin and breaking down, separating out from the underlying cortex involving the inferior frontal gyrus, and similar area of softening, granularity, and almost giving a spongy appearance could be noted in the basal ganglia on the right side. And going further posteriorly, similar areas with dusky discoloration of the cortex of the insula of the superior temporal cortex could be seen, and going posteriorly towards the occipital cortex. This is the left side, showing almost similar appearance with breaking down along the left basal ganglia. This is artifactual separation. So this is the most representative coronal slice of both right and left half, and we see the frontal lobe here. This is the ventricular lining. The ventricular lining was a little irregular, and so the ventricular lining was a little irregular and discolored, but no exudates were identified on the ventricular lining. And this is the area of the right and left basal ganglia, giving almost a spongy appearance, but no really a cystic lesion could be identified, and the similar area noted in the inferior frontal gyrus. So starting with the meninges that were stripped off, we see the meninges here, and this is very minimal lymphocytic infiltrate here, but some macrophages and lymphocytes could be appreciated. This is the PS Alshan blue stain, wherein we can notice that there are numerous yeast form of cryptococci, and this is the HNE stain section. We see a little perivascular lymphocytic infiltrate along the meningeal vessels, some macrophages here, and then the yeast form of cryptococci, which are refractile, and there are surrounding macrophages and lymphocytes. And the Alshan blue stain, the PS Alshan blue stains, brings out the mucin-rich capsule of the cryptococci, and the mucicarmine stain highlights again the capsule of the cryptococci. So in some of the region where the meninges could be seen little attached to it, therein we identified that there was a little granulomatous response around the meningeal vessels with presence of these giant cells and ill-formed granulomas surrounded by some macrophages, epithelioid cells and some lymphocytes. A closer view to show the same. This is the underlying cortex here, and this is the overlying little bit of meninges attached, the macrophages and some giant cells. And within the giant cells also we could identify some intracellular forms of cryptococci. Now in the depths of the sulci we see here a single floating giant cell could be seen, however with a minimal lymphocytic or a macrophage response to it. Now moving to the underlying cortex, there was a very minimal astroglial reaction along this molecular layer. There was exuberant microglial proliferation noted all along the cortical layers, and we could identify these refractile form of cryptococci also within the parenchyma lying loosely floating around. Now this is a panel of pictures to show the response. There was this perivascular lymphocytic infiltrate, very subtle, not very exuberant, noted around some of the vessels, intraparenchymal vessels, and an exuberant microglial proliferation noted within the cortical layers. And an occasional microglial nodule was identified somewhere alone in the pons. The high power to show the microglial response noted within the cortical. These are the neurons which are showing hypoxic changes. We couldn't really perform a CD68 stain to really show the microglial response. Now, this is a section taken from the basal ganglia, and some of the intraparenchymal vessels, especially in the basal ganglia, which was granular, showed capillaries with thrombose, and surrounding it was an infarcted area. But some necrotic macrophages could be seen all around this, and this is a vessel, and we see the characteristic. I'll show it a little later in this. The Werco-Robin spaces are dilated, and they show this almost necrotic macrophages with presence of this extracellular forms of cryptococci surrounded by a halo. So in little areas away from this, very loose ill-formed granulomas with giant cells could be appreciated, and there are numerous cryptococci, both extracellular as well as intracellularly, noted within the giant cells. So the higher magnification to show these cryptococci, and the mucicarmine stain here highlights the cryptococci noted in these areas. Now the panel of pictures to show these new uninucleate forms of little basophilic cryptococci, and the refractile forms, sometimes they are also said to be refractile, and there are these budding forms of yeast form of cryptococci in PS alcin-2 and the mucicarmine stain. In areas a little away from that basal ganglia region, this is the area of infarct noted a little away from that basal ganglia region, and perivascular lymphocytic infiltrate with a little astroglial reaction, and the closer view to show the astroglial reaction away from the areas of those infarct. Now this is a section taken from the frontal lobe. It was a little poorly preserved, but even in those areas we could identify these dilated Werco-Robin spaces with the vessel in the center surrounded by these cystic spaces within which cryptococci was identified, and these have been classically described as having a soap bubble appearance. Another view to show these cryptococci within the dilated Werco-Robin spaces, and the PS alcin-2 stains highlights this better, the high magnification and the PS alcin-2 stains. This is a low magnification to just show the magnitude of the involvement of that frontal lobe, the inferior frontal gyrus, showing these dilated and almost breaking down Werco-Robin spaces and filled with cryptococci. Now moving to going towards the white matter. The white matter again shows these exuberant microglial proliferations. Some of the vessels in the basal ganglia showed perivascular dystrophic calcification, and the lining of the lateral ventricle can be seen here, which is a little stripped off and showing some gliosis. And again, presence of cryptococci in just below the ventricular lining. This is a section from the midbrain. The pigmented neurons could be seen. It was disrupted. Again, little breaking down due to autolysis, but cryptococci could also be identified in the midbrain. Sections from the midbrain had a similar appearance. This is a section of the coronal horizontal cut of the pons and the cerebellum, again showing autolytic changes and a little damage during removal, but it shows these areas of hemorrhagic discoloration in the central pons. And pons again shows extensive microglial proliferation and presence of these hypoxic neurons here. The higher magnification to show the similar appearance, and the section from the cerebellum showing hypoxic changes, but also again the meninges within the cerebellar folia showed presence of cryptococci. and the refractile forms, and the closer view within the cerebellum. Now this is although the cranial nerves could not be well examined, but this is the trigeminal nerve close to the superior pontine sulcus. In a section of this shows a little remnant of the, since was written as 6th and the 12th nerve was involved, we could only examine the 5th cranial nerve. This is a portion of the 5th cranial nerve close to the pons. And it again shows disrupted axonal fibers with presence of microglial proliferation, and the disrupted axonal filaments could be seen on the NFP stain, and presence of cryptococci highlighted by the PS Alchin blue stains. Now this patient definitely had cryptococcal meningoencephalitis, no doubt about it. The primary source of this was from the lung. This is a gross of both the lungs, weighed about 1180 grams. The pleural surface was dull, and there were no fibrinous tags along the pleural surface. The lungs were really heavy and firm, non-crepitant. And this is the cut surface, which shows extreme degree of extensive diffuse consolidation, more hemorrhagic towards the basal surface. No fibrosis or any areas of scarring was identified. There were some hilar lymph nodes. This is a closer view to show the cut surface of the lung, hemorrhagic consolidation. No cystic lesions or any gross focal lesions were identified in all the cuts. So microscopically, lung showed features of diffuse alveolar damage in form of this proliferation or prominence of type 2 pneumocytes with proliferation, presence of macrophages within this alveolar spaces, and early coming up of myofibroblast and some early fibrosis. Another area to show the areas of diffuse alveolar damage here with fibrosis, presence of macrophages within the alveolus lumen, and coming a little bit of fibrin along the alveolar lining epithelium. Another view to show these prominent type 2 pneumocytes, macrophages, and early fibrosis around in these areas. This is another view to show the presence of macrophages, and hyaline membrane, the fibrin-rich hyaline membrane could be identified very focally in very small areas. Now, majority of the sections taken from the lungs had this, also had a presence of this pulmonary edema, and some floating giant cells within the alveolar spaces, presence of cryptococci within the alveolar lumen. And the PS stain highlights the cryptococci present within the, mostly within the pleural fluid or the pleural fluid within the alveolar lumen. The areas where there was alveolar hemorrhage as well as pulmonary edema with presence of this pale eosinophilic material and mixed up with alveolar hemorrhage. Large areas of alveolar hemorrhage were noted. Stain for pneumocystis was also done to rule out presence of this pneumocystis. In view of this little frothy material, pneumocystis was negative, and AFP performed on lung section was also negative. These are the enlarged hilar lymph node, had very firm and grayish white cut surface. The other hilar lymph nodes having the grayish white cut surface. Microscopically showed presence of these granulomas associated with giant cells, and some of these granulomas were, these were the well-formed granulomas. Some of the granuloma had a little fibrotic and hyalinized granulomas with giant cells. ZN stain done was negative, and occasional cryptococci was identified in these giant cells. These are the panel of pictures to show the lymphoid population done to look for a small lymphoid population that was seen adjacent around these granulomas. So CD620 and 3 were preserved, 4 and 8 were negative, but these are not really a very good markers to actually quantitate the lymphoid populations at CD4 and 8, especially in this case. However, 20 and 3 were definitely preserved. The gross of both the kidneys, which weighed 400 grams, the capsular surface was essentially normal. The cut surface had a distinct corticomedullary junction. Microscopically, there was evidence of toxic acute tubular injury with denudation of the lining epithelium and some simplification, and some calcification and hyaline cast were noted within the tubules. The glomeruli were essentially normal, and the PS stain here highlights the normal glomeruli. Occasional glomeruli show presence of these refractile cryptococci, well highlighted by the PS Alchin blue stain, and the mucicarmine stain, presence of cryptococci within the glomerular capillaries. The gross of liver and the spleen, liver weighed 1280 grams. Microscopically, the lobular architecture was maintained, and except for some areas showing macrovesicular steatosis, it was within normal limits. The reticulin stain shows the preserved architecture. The spleen weighed 145 grams. The capsular surface was normal. Microscopically showed features of congestive splenomegaly. The pancreas was normal. And this is the gross of the heart, which weighed 214 grams. The anterior surface was normal. This is the right inflow tract, the right atrium, and the left atrium was normal. The valves were normal, and so was the pulmonary valve. This is the inflow of the tract of the left side, showing this mitral valve, which was essentially normal, except for small areas of fibrosis noted along the outflow tract of the left ventricle. This is the outflow tract of the left ventricle, showing these small, tiny areas of fibrosis, and section taken from this area shows this small area of fibrosis, and with Masson's trichrome stain highlighting the fibrosis just noted just below the pericardial surface, going underlying into the myocardium, indicating some degree of ischemia. This is the gross of the esophagus and the stomach, which was grossly and microscopically normal. The small and the large intestine representative areas showing normal morphology. The bone marrow was within normal limits. The section from the muscle and the skin was within normal limits. So concluding the autopsy findings, in this case, he had cryptococcal meningitis. The primary source was the lung and the hilar lymph nodes, and it had disseminated to kidney. There was diffuse alveolar damage in the organizing phase and acute tubular injury. So this brings us to the question what kind of underlying immunodeficiency he had, and exactly whether he had it or not. So a clue from it can be had from the pathology. This is a good review article that illustrates the differences noted in a HIV positive and the non-HIV individual, especially with the response seen in the cases of HIV positive and the HIV negative. The granulomatous response is especially seen in a cryptococcal meningitis, the CM cases, especially with non-HIV individuals, whereas HIV obviously would have low CD4 count, so would not elicit a response. Secondly, the idiopathic, if there were any non-HIV factors other than the idiopathic CD4 lymphocytopenia which were present in this case. So historically, this is again another review article that illustrates the non-HIV susceptibility factors to cryptococcal meningitis. Idiopathic CD4 lymphocytopenia, we know that it is one of the important factor that causes or predisposing factor to cryptococcal meningitis. Other than that, this article also enlists autoantibodies to GM-CSF and interferon gamma, which have been recently demonstrated as causing susceptibility to cryptococcal meningitis. Besides, this patient with GATA2 deficiency also have increased risk of developing cryptococcal meningitis, and X-linked CD4 lymphocytopenia deficiencies and chronic granulomatous disease patients are more prone to develop cryptococcal meningitis. Thank you very much.
Thank you, Kirti. Kirti, please come and join. So it's really interesting that if this case is discussed in student CPC, is a straightforward case of cryptococcal meningitis, but when it's discussed in staff CPC, it becomes gigantism in an ant. So, that's how the things change. Yes, Dr. Modi, now what do you have to say about it? It was 100% TBM. Yes, Astha.
Sir, don't misinterpret my statement. You told, can you consider TB? The answer is yes. The question is, if you are seeing cryptococcosis everywhere, then you have to accept it. Your question was still, next time the patient comes, we'll still consider tuberculosis as a cross differential. Or rather, cryptococcosis as a cross differential of tuberculosis. Tuberculosis is much more common in an immunocompetent. If there are 100, then there is one of cryptococcosis. So CPC, we accept it. That's why I said, if it is clinical rounds, it is tuberculosis. If it is CPC, we have to accept it.
All right, Astha. So now dual infection or triple infection?
Sir, I think this point has already been made by sir, so I will not exaggerate on this. But then one learning message which I wanted to say was that the way this patient had a catastrophic visual loss is less likely in other infections. And that is why initially also I remember during rounds we had discussed that cryptococcosis can directly infiltrate optic nerve and cause this type of a catastrophic loss even without hydrocephalus and without arachnoiditis. So though ma'am has already mentioned the the shortcoming that we could not examine the cranial nerves, it would have been great if we would have seen Cryptococcus in the optic nerves as well.
Yama, so you want to say it's not the immune responses to Cryptococcus, but it's the direct invasion of the organism?
Yes, absolutely, sir. Cryptococcus has the propensity to develop this type of visual loss we have seen earlier as well.
Spine?
No, sir. No, no.
Osteomyelitic area and arachnoiditis.
No, sir. There was not a consent taken for the spinal autopsy.
Yes, now I think I can see some hands from immunology. Yes, please. See, the cutoff for isolated serial lymphocytopenia is actually 300 and this patient
so
had
this was
400.
400.
Yes, 400. So, you know,
just
that's
close
very,
to that.
in fact, whenever we find Cryptococcus, you know, always CD4 count is done.
Correct.
Especially in non-HIV.
Just wanted to make a comment about the diagnosis of PID. It should be made ante-mortem, not post-mortem. This patient, was admitted for nearly 10 days. So there was ample time to actually do the B-cell immunophenotype or maybe even the T-cell subsets. I think we cannot go away from the fact that this patient most likely had an underlying PID.
Yes, Dr. Aryanti wanted to say something. I believe with the upcoming single dose therapy of 10 mg per kg, you know, with the liposomal lymphoderesin just appeared about last month, I think that would change the whole scenario, because please remember that this, finally you have to save the individuals. And I think this person did receive amphotericin for about 5 to 6 days.
So this was exactly what was intriguing me. We had this ambition and trial NEGM which told that 10 mg per kg single dose amphotericin. Obviously, it was in combination with azole and flucytosine, that it was equivalent and non-inferior, and they demonstrated the serial CSF cultures showing eradication of Cryptococcus. We knew that this patient had disseminated Cryptococcus ante-mortem, but why even after 7 to 10 days of amphotericin, there is still the entire pathology is kind of seeming with Cryptococcus? Was it because PID, even if we probably diagnose, I am not sure, except for some immunoglobulin replacement, whether we'll be able to do much on it. But why was this patient not responding adequately? Whether these cryptococci are viable or whether it is all dead remnants, can we have that clue on pathology?
Yes, yeah, you know, yesterday only we were discussing 3 cases in succession, and that's the point exactly what we made. And I think Kartik was mentioning about immune reconstitution. Please remember that many of the damages which occur in the human body is not because of the direct invasion. It's because of the remnants which act as either DAMPs or PAMs, and you know they act as trigger to which cause immune stimulation, which possibly you know, like I'm sure I'll give it to Kartik to discuss it later. Yes.
So back to primary immunodeficiency. So if we don't have an HIV, then there is a Pandora box. But in this case, when there is a late onset disseminated cryptococcal infection in presence of CD4, CD8 reversal and lymphopenia, so late onset combined immune defects would be there, and there is a granulomas in autopsy. So that can be a hypomorphic RAG type of mutation. Second thing is that recently phenocopies phenocopies has been classified in the inborn error immunities, and autoantibody to cytokines like, as ma'am has also highlighted, GM-CSF and interferon gamma is a great possibility here, and then it would be immunosuppression which would help in this. So it is important to diagnose primary immunodeficiency to treat also.
Yes. Now we have the mycologist. It was a standard Cryptococcus neoformans or some other species. Can we comment on that?
The culture did reveal Cryptococcus neoformans var grubi.
Yes, it was Cryptococcus neoformans var grubi, which is now called as Cryptococcus neoformans. So we had analyzed about 125 cases of cryptococcosis over a period of 1.5 years, and we found 15% around patients were HIV negative, and most of them were organ transplant recipients, most of them renal transplant, and also malignancy were few, liver disease, and in case of rheumatoid arthritis who were treated with steroids. 2 or 3 patients had no apparent risk factor, and we also took samples for blood samples for those patients. I think this patient blood sample I have to check if we can do any PID or any other workup. Sure. So genetic polymorphisms have also been associated with HIV negative disease, like in TLRs, mannose binding lectins, and in case of other markers like Fc gamma receptor. So that we were looking for. So maybe I can.
That will be a really welcome step. Yes, Dr. Siddharth. He is a senior resident in adult rheumatology.
I was just wondering the cause of the pan digital clubbing and the recurrent episode of jaundice this patient was having. There was no evidence of chronic lung disease or any cardiac lesion in the autopsy. Second thing, ante-mortem, the 2 pointers that were making us think of a dual infection were the arachnoiditis and the vertebral osteomyelitis. So just wondering whether we could assess them on histopathology.
I think the spinal cord and autopsy was not done in this patient. But however, if you have to consider an adult onset CVID that started pretty much when he was around 30-35. We don't have any evidence on autopsy of a chronic immunodeficiency. He didn't have any evidence of bronchiectasis. He didn't have any evidence of hepatitis. I don't think any evidence of any chronic infections were there noted on this. If we assume that he had an acquired immunodeficiency disorder, either genetic presenting late, it could be a genetic cause of immunodeficiency that is presenting very late into his adulthood, that he didn't have any chronic signs of chronic infections in this patient. Secondly, this patient, this all disease triggered when he had received CAM for his jaundice previously. As we know, steroids are given just like Prasad in all of in the sector. So we cannot run away from this fact. This patient was given a high dose methylprednisolone, good enough to make a elephant run also. So this patient was given high dose of immunosuppression, high dose of methylprednisolone, 1 gram for 5 days. That can itself cause a disseminated cryptococcemia. There is hematogenous spread everywhere. Every part of the body was involved. There's even on, I've seen lungs, liver, renal also, it has been disseminated. So there's no doubt whether he had dissemination secondary to that. And to see if they have immune reconstitution syndrome, we can look at the macrophage activation in this patient, whether there was actual phagocytosis of the cryptococci of the cryptococci in the brain itself.
Yes, in that you wanted to say something. Well, we are giving a lot of importance to the host factors, but we are forgetting about the agent. So this person was working in a shoe leather factory. What about the number of pigeons? Nobody even talked about the pigeons. We are not even talking about the agents. If you are in that environment, whether you are immunocompromised or competent, it is immaterial.
So pigeons are ubiquitous. There are pigeons.
Not ubiquitous. The numbers, I'm saying.
There are pigeons right outside my hostel.
Oh, yes. But I think the numbers, if you are exposed, it's like TB.
So, one thing is that isolated CD4 lymphocytopenia cannot be made, diagnosis cannot be made during the acute illness, number one. You have to demonstrate low CD4 counts at least twice, 4 weeks apart. So, clinically and by definition, he doesn't meet the criteria, so that is off. As far as high dose steroid is concerned, why not other infections? Why not bacteria? Why not TB? Why not other infections which are more common? Why only Cryptococcus? So I think that he was having a nidus for there in the lungs, and once we gave the steroid, it just like it just like spread everywhere. So that is how I would now retrospectively look at this. Why he had Cryptococcus focus? That is something we need to really investigate.
Yes, Dr. Radhika.
I really have a question for the experts. Does one HIV ELISA completely exclude HIV infection? The experts can answer that. Second is when Kirti showed us the granuloma, it was you also yourself mentioned they were very ill-formed, poorly formed granulomas, occasional giant cells. So I still feel you still think that this individual could be immunodeficient from the cellular response. What is your opinion, Kirti? And although you showed us a lymph node, one hilar lymph node, what was your assessment of the other lymphoid tissues in the Peyer's patches, etc., which would you still favor immunodeficiency in this individual from your cellular response assessment?
Yes, Dr. Bishop.
I haven't seen the slides myself, but I was listening to all the discussion. To me, this is a straightforward case of disseminated cryptococcus. Indra very rightly said, there are always nidus in the lungs which is dormant for months and years. And once there is a trigger, it can disseminate. The only problem is that had we sampled more areas, had this patient lived little longer, the other organs may have been, would have been involved. Here we have a very nice cryptococcus in the glomerulus of the kidney. So it was basically being spread hematogenesis. As far as the neurological manifestations are concerned, I don't think there is any problem in explaining any of the manifestations. The cardiac, there is meningoencephalitis, which is actually, this case is loaded with the cryptococci. And mind you, these are viable. These are not dead crypto. There is no dead cryptococcus in the CSF. So this was really loaded with the crypto. Cranial nerves are very commonly involved. Optic nerve would have been involved. The only point which I have not understood is the presence of small infarcts. And Kirti showed a lot of them. But was there actually vasculitis, real vasculitis, the cause of these infarcts, or was it was only compromise and vasospasm or something? Because Kartik also mentioned that up to 8% of the patient can show vascular involvement. I'm sure there would be some vessels which may show active vasculitis or actual vasculitis rather than just perivascular. As far as granulomas are concerned, I would agree with Radhika. They are not real, very good, well-formed granulomas. Such CPCs have been done. I have myself done 2 CPCs where there was florid giant cell reaction. And Kirti has brought out the point that the non-HIV patients are more likely to show this kind of granulomatous, which is okay, but it is not 100%. I mean, it's a good observation. We have seen all kinds of cryptococci here. So I think, as far as I am concerned, CNS manifestation, nothing. Everything is explained on cryptococcus. Thank you.
Yes, Aman. And I think that will be the last comment. But I think it's a very loaded statement that we are all loaded with cryptococcus, which remains.
Dr. Sunil Arora is in charge of the ICTC lab, but whatever the NACO guidelines are, the first screening test has to be the HIV. The kits are chosen based upon very high sensitivity. So if it is done from the ICTC, was this test done from the ICTC? So it is highly unlikely that this would be negative.
Yes.
We haven't really seen, but the problem is there with the readily available kits, where we've seen sometimes that they brought from the countries like China and all. They have false negative reports. They are not imported in the way they should be. They have the bedside kits which are used. That's number one. Number two, we published our experience of cryptococcus in HIV. It is very unlikely for HIV individuals to have cryptococcus at CD4 of 400. Generally, it is 100 or 200. They have lower CD4s. I think out of 92 patients that we published, there was hardly any patient who had more than 200. So that is